meeting is being recorded.
That was loud.
Hi everybody. We've had about 75 people sign up today, real mix of people coming through. It's interesting, we advertise these events for people that are involved in embedding the roles within primary care, and it really makes you realise how many people, how many different bits of the system, the different kinds of people that are instrumental in making sure that these roles within primary care are embedded well and being used in a meaningful way. So yeah, we've got about 70 people signed up today, 75, 80 people signed up actually, sorry, at more recent count. It's a real mix. I was just saying we've got some PCN managers, some practice managers, some CDs, some managers of service, some commissioners. I think there's a couple of training hub people signed up, and then obviously some frontline workers. It's been really interesting seeing social prescribing link workers, some of the lead social prescribing link workers signing up for these events, because I think it really speaks to kind of how involved social prescribers are in thinking about how these roles are being used. Welcome everybody, nice to see you. I think it's probably, where are we at? What time is it? It's probably worth starting. I'm sure people will arrive as we go. We're recording the session. I'll mention that a bit in a second. But I guess it would be useful to start off by introducing myself. So my name's Leanna Martin. I'm I wear a few different hats actually. I'm the Regional Learning Coordinator for Social Prescribing across London. And I work at the Healthy London Partnership and sit within the Health and Inequalities team as part of the Personalised care gang. So we it's maybe slightly misleading. I guess the main focus of our work is to think about the three roles and how they can be turned towards tackling health inequalities, and we do that through a number of different projects. And two key focuses is supporting the workforce and also supporting the system that is employing the workforce and embedding the workforce, which brings me on to sort of my more recent hat, which is the PCN advisor. And I guess this is some of the work we were doing in a more informal way, and in supporting link workers, we realised that there was just definitely lots of PCNs that kind of really wanted to get on board with how these roles can be supporting some of their more vulnerable groups and thinking about how to use them in a more strategic way, and that kind of led to the PCN advisor work. So today's session we host, I share the role with a lady called Hina Shahid, who can't be with us today. She's a GP in North West London and really passionate about tackling health inequalities, and has got a background in public health and worked alongside the VCSE sector for many years. My background is in community development. I came to Healthy London Partnership from the Bromley by Bow Centre, and have worked for over 20 years in the voluntary sector and business startups, and I think have touched on and done social prescribing in many different guises over the years. So came to this work kind of by accident actually. But today's session, so Hina and I run a monthly session for anybody who is involved. It's open to anybody that's involved in embedding the three roles within primary care. We've got a backlog of sessions. I think we started out last July. So you can find a backlog of all the various different sessions that we've run around kind of the three roles, how they work together. Last month we did a spotlight on care coordinators. And this month is a chance to have a look at the health and wellbeing coach role and think about how the health and wellbeing coach roles can be turned towards tackling health inequalities. Jenny, could you go to the next slide? So I've mentioned a little bit about my role as the PCN advisor. So we host these monthly sessions, but we also are building a bit of a network of those who are employing and embedding the 3 roles. I can say a bit more about kind of the support, some of the offers of support that we are providing, but we have some surgery time for anybody that wants to book in for a chat with Hina and myself to find out more about the roles and talk through maybe some of the one-to-one, some of the challenges you're facing. There's a WhatsApp group for anybody that's interested to connect with other people that are supporting these roles. Jenny and Hina are, so Jenny's a member of our team who's been supporting this work, and they're working on a toolkit looking at pulling together some of the resources that support the embedding of these roles and some really nice case studies of where this is working well or maybe where it's not worked, where there's been an approach that's not worked. Do you want to go to the next slide? So today's session is, we've got a few different speakers, but we're hoping that as a result of the session, you'll come away understanding a bit more about the role of the health and wellbeing coach. So we'll get some clarity around what the role of the health and wellbeing coach. We'll have some examples of some of the things that are happening across London. We'll hear from a clinician about the value of the role and why health and wellbeing coaches can be really transformative for the work of primary care. We all know that as we move into ICSs, what might the ICS's role be in supporting this work? And we're going to hear from North East London. Geeta, who's just arrived. Hi, Geeta. About how this can be, how a kind of a bigger footprint, an approach to supporting these roles and thinking about how they're embedded might work. And then from a health and wellbeing coach, Caroline, who I'll introduce in a second, about how you might best support a health and wellbeing coach. Now, we'll move on to case studies as well at some point, and then there might be some time to open up to the room. We've definitely got some people who are employing health and wellbeing coaches in the room. It'd be really good to hear from you now, actually, about some of the challenges that you're facing. So just quickly to say, we're recording today's session. It will be uploaded to the YouTube and the HLP website, and we will circulate the recording and the slides. There's quite a lot of us in the room, but it is quite an informal session. So please feel free to chat to each other in the chat box. Feel free to change your name so that you can include maybe the borough of London that you're working in, or maybe your job role perhaps, so that you can look through who else is in the room and see it as an opportunity to maybe pick up with people outside of the meeting as well. Because there are quite a lot of us and it's quite difficult, there's not many of us managing the event. We've got a Slido, so if you hover your phone, the camera on your phone over the URL on the, what's it called? I've completely... The QR code. Thank you. Brain melt. Over the QR code, that will take you through to Slido, and that it would be really great if you've got questions for the speakers, any of the speakers today, pop your questions in Slido. You can also, if you haven't got any questions, keep an eye on it, because there might be things that other people are asking that you want to vote up. So we're trying to be a bit democratic about which questions we get answered. We've got an hour and a half. It is, it's quite a long time. We might not need the whole session, but often it does evaporate. So please, if you can get your questions or vote up the questions that you want to hear the answers to, we'll try and tackle some of those as we go, because some of the speakers need to leave before 1:30 today. So there'll be opportunities as well. I'll be coming out to the room to sort of hear from you, maybe put some questions out there at those points. It's totally fine for people to sort of take themselves off mute. It'd be good to hear, in your sign up today, for today, you've shared some of the challenges that you've had to embedding health and wellbeing coaches. If you go to the Slido, I don't know have we got a slide, Jenny, for the main challenges to embedding the health and wellbeing coach?
Yeah, we do. I can just launch.
So I've just launched an open poll. If you would like to join us on Slido and tell us, what do you think are the main challenges to embedding health and wellbeing coaches, which will help inform some of the speakers today, what they might cover. Just looking through the sign-ups, it feels like there's quite a lot of conversation around how these roles can be used alongside the other roles, supervision, perhaps consistency of health and wellbeing coaches and how they're being used across a borough. I don't know, is the Slido working? It doesn't matter if it's not. We don't have the slide up in front of us. Jenny?
Yeah, it's working. I can just, I can share the...
Oh, okay.
If we, yeah.
Oh, fab, sorry. For those of you that just recently joined, if you want to change, in your name, if you want to put your, like maybe your borough or your role after your name. If anybody wants to come off mute and talk about some of the challenges they've faced in embedding the roles. We've got a shy room.
In the chat box that someone was asking about supervision requirements.
Hi, that's me. I'm Sandra. I'm a PCN manager in Barnet. Can you hear me?
Yes, we can.
Yeah, hi. So one of the challenges we've got actually is actually even starting with the role. So I've been asking for a while. I have contacted Healthy London and I'd asked the Barnet Training Hub, who are who would help provide hopefully support about the supervision requirements needed for the role. And as I understood it, there would be a workplace supervisor, which could be GP or manager, but then there had to be an actual health and wellbeing practitioner as a supervisor. And trying to get any more information on that has been really difficult, and what that supervision looks like and how that would be provided, whether it would be funded. And the training hub certainly didn't have any information and said they would look for me, but that's been quite some time ago. And I've got 2 care coordinators who are really keen to transfer potentially over to the role, and we're keen to support and not lose them. But obviously we want to make sure there's supervision and a proper structure to support that.
Ah, yes, your email is now ringing a bell, Sandra. We'll definitely be able to pick up some of those questions today. We've got a couple of people speaking to, so in South West London, Mohan and Caroline both can speak to kind of like how they are tackling the supervision issue in their bit. I'm not sure if integration, supervision. So I'm just reading out some of the things that are on Slido. Feeling quite disconnected from the PCN. Obviously, these are quite specialist roles. In some cases, they're employed by external organisations. How do we balance out? Maybe those individuals are getting some of the supervision and support that they need, but how do we make sure that they're embedded within the PCN? Where do we find money for training? This is a common issue across all of the roles. The other thing to say is that all of the questions that go into the Slido today, we won't be able to necessarily cover all of those questions. We will do our best, but in the absence of covering questions in today's session, we will go away and find the answers and put those into an FAQ. I think the other thing to say is that this is very much an emerging piece of work, and we're all exploring as we go. And I think the purpose of today's session is to really share with each other what we know ourselves. And hopefully we can be the conduits of kind of the intelligence that's out there in the system, pull it all together and share it back out after the event for the things we've covered and maybe the things we didn't get to. Let's go to our first speaker. So who better than to tell us about the health and wellbeing coach role, and who is a good referral? Who might health and wellbeing coaches be working with? Than Caroline Haynes, who is the mentor, the regional mentor for health and wellbeing coaches across London, and coordinates the network for health and wellbeing coaches and hosts a regular monthly meetup with them. Caroline, over to you.
Hello, so I'm Caroline and I am a health and wellbeing coach in East Midlands Primary Care Network. The mentor for health and wellbeing coaches. So what that means is that we provide network for health and wellbeing coaches to support each other. We have meetings once a month. There's also national peer support as well that happens once a month. Sorry, the sound isn't clear. Can you hear me okay?
Oh, that's better. Yeah, it was working earlier. That's better now.
Really close again. My face is in shadow, so you haven't got my big face staring out at you. So what is a health and wellbeing coach? I'm assuming that most people here know a little bit about what a health and wellbeing coach is. And on this slide, we've got, I guess, the 3 personalised care roles. The health and wellbeing coach really targets people for behaviour change. So anyone that can make a change to their behaviour to improve their health is a good candidate for health and wellbeing coaching. So what health and wellbeing coaching will do is that they will help the patient to set a goal. So what do they want to achieve for their health? And then we will help them identify any obstacles or any blockages or anything that might get them falling off track, and we will help them to navigate around those obstacles so that they can go on their pathway towards their goal. And I guess the end result, hopefully, being that they improve their health, and that can be their physical health or their mental health, and that they have confidence in managing their own conditions. So we increase their confidence in managing their own care. So I won't talk about the care coordinators and social prescribers, but if you've got any questions, I guess some of the questions might be around where the boundaries are between the 3 roles. And really, you know, if you have all 3 of these roles in your practice, it would be really important to get these 3 roles together and actually talk to them about where these boundaries are, because where you might only have 1 or 2 of those roles, the boundaries might be slightly different. So I guess the boundaries are very specific to between PCNs.
It might be useful for me to chime in. I guess if we're thinking about an overview of the 3 roles, the social prescribing link workers are very much addressing the social determinants of health and connecting people to community assets. So they're taking time, you know, all of these roles will be taking time with the patient, but the link worker will be connecting to community assets. The care coordinators will be ensuring that there is continuity of care and providing allyship and advocacy and ensuring that people can better connect with the health service and the support that's being offered by the health system. And then health and wellbeing coaches are looking at that longer term behavioural change. Caroline, can you give us some examples of some of the patients that you've worked with?
Yep. So I work a lot with obesity patients and patients who have got long-term conditions that might be connected to obesity. So for example, diabetes, high blood pressure, cardiovascular disease, and then also mental health patients. And I guess the boundaries for mental health patients are a little bit more tricky, but I guess anyone that can focus on a goal rather than being really caught up in the past. So anyone with a mental health condition that is relatively stable, isn't really risky, and who can focus on making a goal for the future, we can help them get to that goal.
You've got a slide on who is a good client. Is that what you've covered then?
This one, yes. So who is a good client? So anyone that would like to, who has a health condition that can be improved using behaviour change. So that's not saying that they should only use behaviour change. Obviously, they presumably might be on some medication. So, you know, carrying on with medication, but also trying to do everything that they can to change their behaviour using lifestyle or diet or exercise, or perhaps changing thinking patterns to improve their physical or their mental health. And I'm sure, you know, we've all had experiences in the past where we wanted to make a change and potentially we haven't done, because it's hard making a change. It requires a lot of effort and a lot of focus. And for some people, that is very difficult and they need a little bit of help to get there. You know, a really good example is, you know, in January, the gyms are always full with people that have decided to join the gym, and then come February, the gyms are, you know, not very quiet at all. Are really quiet because everyone has decided that actually that's too much effort and it's too hard, and actually it's not that important to increase their fitness or whatever their goal might be. And so health and wellbeing coaching can really help people to make consistent change. As clinicians, you might have had people come through your door who, you know, year on year, who you say it would be really beneficial if you lost weight. And then, you know, they come back the next year and they've put on a bit of weight, or they come back the next year and they haven't lost any weight. And that's because it can be very hard. And there's a lot of information out there in terms of, especially around weight loss. There's hundreds of different diets, or thousands of different diets, probably. You know, the internet is full of information about how to do it. But, you know, the problem isn't the lack of information. The problem is helping people to take that information on board and pick the bits of information that will help them within the context of everything else going on in their lives, and helping them to navigate those obstacles and really actually get conscious to what their obstacles are, and then helping them to get around them. So typical people that we might help are people with diabetes or long-term health conditions, mental health, and obesity. And I guess, you know, these are all great clients, but what I would say is that the clients or the patients need to be ready to put in a bit of effort to change. You know, sometimes someone might go to the GP with knee pain, and the GP might say, you know, you would really benefit from losing weight. And actually the client that isn't what they wanted. They wanted some painkillers. And so although a health and wellbeing coach can help them if they kind of take that on board and think, actually, I am ready to lose weight and I do want to do this, a health and wellbeing coach can help them. But it's just worth a little bit of a conversation before they're referred to find out whether they actually are willing to put the effort in to make some changes. And I guess that comes down to the last point, which is motivation. A health and wellbeing coach can help with motivation. So lots of people have no motivation, but they have to have a little bit to start with. And I guess the GP telling you to lose weight isn't going to be very motivating in the long term. That isn't really going to help someone to dig deep and to put the effort in and to make the changes when they're finding it really tough, because it's an extrinsic motivation. Whereas, you know, if you said to someone, what's important to you about losing weight? And they said, well, the GP told me to. And then you say, well, why do you want to lose weight? They might come up with, you know, loads and loads of different reasons once they've had a think about it. And those reasons are the intrinsic values. And that's the thing that's really going to help increase their motivation levels to be able to do that difficult thing that they want to do.
Really? Yeah, I had a couple of questions. So one, what is health and wellbeing coaching not? Being used as, but it really, maybe it's not right, it's not appropriate.
It's not counselling. And that can be really difficult to where to draw the line, and especially because lots of people want therapy and want counselling, and the waiting list is really long. And sometimes this can be viewed as like a stopgap before, you know, they can be picked up by IAPs. And I guess they're also not a dietitian. So if they want a, you know, specific diet plan designed for them, that's also not what it is either.
Someone's asked quite a specific question about, you know, but I think it speaks to the broader point of what types of people a health and wellbeing coach can support. There's a question here from Tamsin. Would they be able to talk to parents who are vaccine hesitant about vaccinating their children?
I guess you can help them come to an answer, but you can't give advice. I guess coaching isn't advice giving. So if you can help them to explore their fears, and you can help them to explore, you know, think about the pros and cons that they've come up with, I guess there's probably not an ideal scenario, especially if they're, I guess you can't influence their decision.
This is a really important point about the personalised care roles more broadly, and how, you know, by their design, they should be there to empower the individual to support themselves. And I think that's exactly right. The coaching approach enables somebody to get more in contact with their own reality and what they think and feel about something and what they need to do. So yeah, it would be not to convince somebody to vaccinate their children, but maybe to explore how they feel about vaccinating their children in a safe place where they're not going to be judged, and they'll be asked questions which will give them space to the lovely phrase, it being a time to think. Mohan.
Hi. I sort of put a question there just to ensure that Tamsin was referring to health and wellbeing coaches, and I completely agree to what you both have been saying. So I think if you're going to counsel someone about doing a procedure or doing a vaccine, you probably need to know all about it, don't you? I think if you're then not able to answer a lot of those questions, then it's quite hard to then say, well, these are the risks, these are the benefits, this is what's not good, this is the latest evidence. And I think for a more effective consultation or discussion around that particular topic, which is about vaccinating children, you probably need people who've been involved in that. And health and wellbeing coaches can certainly help with that journey, but it may not be the best place for it. So I probably just want to add that in, because there's so many things that health and wellbeing coaches can do and make such a huge benefit for, and make sure you use their assets, not something else which they're not particularly designed for. So I kind of want to make that point clear as well, that utilize their skills, not someone else's. Thanks.
It's really helpful, and actually we'll stay with you, Mohan. We're going to hear more from Caroline later about how you can support health and wellbeing coach, what are the conditions they need to thrive. But let's go to Mohan. So please feel free to keep putting your, it looks like no one's really using the Slido for questions, so please feel free to put them in the chat and I'll pick them up. Mohan is one of the clinical leads for personalised care in South West London, or the clinical lead for personalised care in South West London. But I would say a long-standing advocate of these three roles, and probably in particular health and wellbeing coaches. Somebody mentioned you were wearing a brilliant T-shirt yesterday, Mohan. Medicalise, don't medicalise, socialise. There it is.
There it is.
Yeah, we need more Mohans, but yeah, would love to invite you to talk about kind of the value of health and wellbeing coaches and why they're important for primary care.
Thank you, Leanna, and thank you for asking me to come and speak. I've got another T-shirt which is "Don't Medicalise, Personalise," which is actually more attuned to health and wellbeing coaches, and that's about sort of personalising care to what matters to you. And I saw a couple of questions on Slido about the differences between the roles, and hopefully I'll be able to sort of give explain what we've been doing in South West London. So I'm the clinical lead for personalisation in South West London, and so I was going to touch upon why health and wellbeing coaches are particularly important, how you can embed in your primary care network. So there's a question around that, and evaluations of how they link in with some of the other roles. So thank you, Bailan. If we could move us on to the next slide. Thank you, Leanna. So why are we doing health and wellbeing coach? I love this slide. So Alf Collins came up with this slide last year or before COVID, and for me it really depicts why we're doing what we're doing with the personalised care roles, and an advocate for all three roles, because they're really, really needed. And so there's quite a lot of information there, but I want to sort of get your mind looking at the one at sort of around 11 o'clock. So 70% of NHS spend is managing long-term conditions. So a huge bulk of the NHS fund is on long-term conditions. And then if we look at 2 o'clock, it says 40% of patients feel part of their long-term conditions. So that means 60% of individuals aren't feeling part of their long-term conditions. So whatever we're doing is not really working. And then that results with our statistic at 12 o'clock, which says £300 million worth each year is being wasted. And so suddenly you can see, look, we're spending a lot of money on people who don't really understand what's happening to them, and we're wasting money in the meantime, and hence medicalising them, hence the phrase "don't medicalise." And so what do we need to do to change those statistics and make sure that people become empowered? And that's where these health and wellbeing coaches are so effective, to make sure that we get behaviour type discussion conversations for individuals so that they take control over their life. It's no point the clinician or the doctor saying, do this, do that, or take this pill, or take that investigation, because if they're not included as part of the conversation and they don't want to do it, they won't. And I kind of, so I think it's really important that we acknowledge that and get these health wellbeing coaches who, as Caroline has mentioned, help with those small steps and gets individuals to the starting point so they can have a conversation about their long-term condition. And with the social prescribers who look at the social issues, together you've got a very, very powerful workforce. One looking at the social determinants of health, as Leanna mentioned, and one looking at that behavioural one-to-one coaching as well. And the GP and the care coordinator, you've suddenly got a very strong sort of non-medical workforce to really address some of these root cause problems which you've not been able to do before. And then there's a couple of other stats there which are also quite helpful. Next slide, please. So how do you embed into your primary care network? So I think this is important for all roles. And so you can probably use this spreadsheet or this table for other roles. And it's how would you put anyone into your network or into your environment? So, 5 years ago when social prescribers were implemented into practice, it was a new environment for them. So what do you have to do? So it's really important for the health wellbeing coaches to pre-plan your environment, make sure that the staff are aware of what's coming, explain to them what the purpose of their role is, making sure that they fit into the environment so they feel comfortable, so they're not feeling like as though they're a bit of a nuisance. They get to know all the members of staff. They come to clinical meetings, staff meetings, and really feel part of the team. So that's a pre-plan, so before they've even arrived. And then I think also mentioning it to the social prescribers and care coordinators about what their roles are, where there's potential. I wouldn't say overlap. I don't think there's that huge overlap, but I'm biased. But I think what you may be looking together at and what you might be looking at in terms of feeding off each other. And I think if we look at those, then you've planned or you've pre-rehabilitated the working condition to make sure you get the most from it. I think once they're in post, again, induction, having a kick-off meeting. So we had an online webinar. We had a whole network online, and we had a few of the GPs and all the members of staff, and we did a opening ceremony type thing. So it really kind of gave it that kickstart. The fire started. So that really helped. And then again, ensuring that the health wellbeing coaches attend clinical meetings, socials, and then there's that constant feedback. So when we first started sending referrals, are they appropriate? And if they're not appropriate, then why not? And which type of cases would be useful? Because what you don't want to be doing, and going back to Tamsin's case there, Tamsin's case, you want to be sending the right cases to get the most from it. If you send the wrong cases, you won't get as much from these health wellbeing coaches. And then what happens is you feel it doesn't work. And it doesn't work because we've not sent the right cases for them to really address and really make a difference. So I think it's really important, that two-way feedback in order to sort of ensure that it's embedded as well as it can do. And again, it's the same as the social prescribers. And I've got BAU, business as usual. So I think it's really important to update on feedback, appropriate cases and follow-up, which I've mentioned. We have now utilised the health wellbeing coach as a massive asset. And we've got 2 in our primary care network. We're about to get a 3rd next year when the new funding comes in. And we actually, with all what's happened in the past 2 years, obviously the morale of staff has been not particularly great, and it's been quite a difficult time. So we actually got our health wellbeing coaches to do a webinar for all the members of staff of the primary care network. I think we had about 40 odd who turned up, and it was an opportunity to give them some tips about how to look after themselves for the first half. And then we had for the second half an hour talking about the actual role and what kind of cases really fit into it. So it was a great way of giving something back to the network, and also sort of advertising, how good the role is and what kind of cases would benefit from it. And as a result of that, we've had some great feedback, constant referrals. I think we've got about a big waiting list still, and which is why we've had to get a second health wellbeing coach. So yeah, wonderful. And supervision, yes, really, really important. Again, need to have that supervision in practice for each of the practice they're working at, certainly in terms of being able to support the health wellbeing coaches in case they were to come up with a difficult case or difficult scenario. We've had a few mental health cases where some have gone a bit psychotic, and therefore what do you do with those? And they're inappropriate referrals. And you need that sort of point of contact to be able to talk further. So it's really important that happens. Regular catch-ups as well, just to sort of ensure how everything's going, how the feedback, how's the referral numbers, how the cases, some of the successes, some of the work we need to work on. And I think the health wellbeing coaches linking with each other as well, sort of finding what works, what doesn't work. What are you doing? What are we doing? What learning have you had? And I do think it's important to have that clinical supervision as well, to ensure that there's developmental opportunities for the health wellbeing coaches, and also they get their supervision, which is bespoke to what their particular role is. And I think a GP supervision does it at the practice, but I think you need a health wellbeing sort of specialist supervision as well. Where that funding comes, it should come from the network. If that's not available, then we need to be exploring that from training hubs. If not at a system level, would be my sort of broad answer to that. Because this is the role you want to stay. This is not a sort of honeymoon period. Do it for 6 months and see what happens. These roles are here to stay, and if you use them wisely, you'll get more from it in return, and therefore you'll see big differences. So we need to make sure we adequately equip them with the right tools to be able to make magic. Thank you. Next slide, please. So Caroline touched on this. So in terms of evaluation, it's quite important that you sort of set your criteria for referrals. And so we looked at management of long-term conditions, so obesity, diabetes, cardiovascular. We've got some measurements there. The HbA1c, BMI, cholesterol, blood pressure. And so we were looking at measurements at the start, and then hopefully we can measure them a bit later on to see whether there is a difference. Would be one way. We've got the soft measurements, so the health and wellbeing scores. We started off with PAM, and suddenly PAM kind of cleared off, didn't it? Last April, we weren't using it on the NHS, so then we had to switch to ONS4, which kind of disrupted our evaluation. But yeah, whatever tool you use, it's good to have that sort of patient feedback or patient feeling about themselves. And other measures can be things like GP appointments. So do you reduce your GP appointments? Is the patient more motivated now to take their medication? Has their medication increased as a result of them understanding why they want to take it, why they want to get better, et cetera, et cetera? And then will that result in better long-term control of your condition? And so these are some of the examples we're looking at. And I think it's really important that you identify what your problem is in your primary care network based on your population health, and then set these metrics based on that. So not just do it for the sake of it, but like, what is it we're really trying to address it? What is our issue? And obesity being a big issue as well, is something which we're finding is a big problem in our network, something we're really keen on coming up with a strategy for. So that's how we came up with our referral process. And that will then be linked in with your evaluation. So your soft measures, your GP appointments, even the clinician satisfaction, and also impact on a wider service. So, and the reason why it's important to evaluate is to sort of reassure yourself that it's working and what you're doing makes sense, and also to sort of convince other stakeholders and other members of your network or other CDs as well. Thank you. So we did some evaluation where we've got an interim report, and we've had quite small numbers from repeated follow-ups, but the measures we used were wellbeing scores, PAM and ONS4, and as I said, we haven't got a full evaluation of that. We did get BMIs of 15 patients, not a huge amount, for before and after. What we did find that some patients weren't that keen on getting BMI'd or getting weighed, which was interesting. And so that was a bit of a challenge. But of the ones we did, we saw a reduction of 5% of those patients. Some of them were a lot bigger than that. Some of them went down 15 kilograms, which is wonderful, and are real advocates for that. And then qualitatively, some great quotes there. When I look back, I've lost 3 stones. If it weren't for her, I wouldn't have got this far. So this is something which, 3 stones of weight, massive amount or big amount, which has really changed the individual's impact on what she can do. Before she wasn't able to do it. Now she's been able to lose 3 stone. Now she's been able to look after her long-term condition, and things change in terms of her process of being able to do all kinds of things. Currently, health wellbeing is better. And regarding my GI, I'm seeing them less, and my headaches are depleting. Wonderful. I mean, that's what we want. We want these patients to be cured, or better cured, without in ways which they manage to control themselves with the support of the health wellbeing coach, and not being medicalised. So really, really good in terms of seeing that feedback, and that reflects a lot of the patients who have gone through this program. There's another good quote there at the bottom as well. But you get the picture that this really does work. But you need to pick your patients or pick your criteria wisely in conjunction with your health and wellbeing coach. Otherwise, you won't get these results. You won't get this feedback coming back because you've got them to do the wrong role. And then here's small feedback of the satisfaction. We had 15 cases, and it's out of 10, so some really good feedback in terms of how they felt about the role. And when I first referred patients to the health and wellbeing coach, I'm not sure they really understood what it was, and a lot of them were like, "Well, go on then if you say so, doc." And I think this is part of the advocacy and part of the wider picture that we can all say. So not just GPs, but also patients and also nurses and the reception crew. Everyone's saying that this opportunity exists, and we do have a self-referral mechanism, but it's not been activated. It's not been as big of uptake as we would like, but there's plenty of work for a health wellbeing coach to do. And I think that brings me to my final slide. So how does they link in with the other roles? So there was a question about social prescribing. I think, Leanne, you pretty much said it, didn't you?
I'm really sorry, Mohan. Is it all right if we park this and come back to this slide? Just conscious that Geeta's got to leave in 10 minutes and she's on a deadline. Is it?
Yeah, sure. Yeah.
Sorry.
Yeah.
Lots of really, really good stuff there, but I mean, we can definitely come back to this. Geeta, are you around?
I am.
Hello.
Hello. Can you hear me okay?
Yes, we can hear you perfectly.
Marvellous, great.
A tour de force, a workforce lead for London ICS, and has got kind of a really fantastic background in supporting the workforce. Maybe you should talk a little bit about your fantastic, like the reason that you've landed in social prescribing and supporting the personalised care workforce. Your training hub background.
Oh yes, so hello everybody. I'm Geeta Malhotra, if you don't know me already. I'm North East London Workforce Development Lead for Personalised Care. I'm a Newham resident, so I feel very passionately about all this stuff. I've worked in health, education, policy for about 35 years, a nurse by background actually as well. So I think all of those things have kind of framed my passion around personalisation, the bottom up personal testimonies, and actually what matters to the person. And what we're talking about here is a fundamental discourse challenge, that we've introduced something in called personalisation into what is ostensibly a medical model and quite a linear model. So not without its challenges, but super exciting. And I've been working most recently, a few years ago, I was a programme director for CPEN in North East London. So I'm now working across North East London 2 days a week in the ICS, soon to be, on personalisation. So I started out on social prescribing last year, and I guess very rapidly last May, health and wellbeing coaches were starting to come into post in this kind of ad hoc way, and those anecdotal conversations were starting to, I guess for me, cause a little bit of concern. Next slide, please. And just a little bit of context, North East London is made up of 7 boroughs, Hackney to Havering, got a population of 2 million, 47 PCNs, last count 272 general practices. And what we have at the moment are 23 health and wellbeing coaches in North East London. And that doesn't mean that's 23 in 23 PCNs. Like Mohan was describing earlier, we have one PCN that's got like 3 coaches in it. We vary from one borough that's got about 8 coaches in it to another borough that's just got 1. So that level of variation, and I guess for us and for me, was starting to highlight that there's this sort of disconnect and potential isolation for some coaches. And so I guess from a North East London point of view, from a system point of view, what's within our gift? I guess that there is something around what we can do that is looking at what is core and common, doing things at scale. And it isn't about replacing what a primary care network does, but it is actually really trying to kind of attend to what is within our gift to do, that we can do right across the whole system. And I guess based on the work that I've done on social prescribing, there's an absolute commitment to strong, discrete, clear role remit and recognition and identity. And that will come, I'll talk a little bit more about what I mean by that when we come to the further slide. And so after May and all these ad hoc conversations and anecdotes of, you know, an odd coach here just saying, I'm not sure what I need to do. I've been given a blank sheet of paper. It's exciting, but also I'm kind of having to prove my worth. It started to kind of, it created what we've described as discovery work. Wanted to know who we had, where they were, which surfaced 23 coaches in North East London. And I guess it also highlighted in the discovery work, variation across three things: understanding of the role, nothing new there, and its potential. This sense of belonging in PCNs, and it replicates some of the experience of social prescribing link workers when they arrived in 2019-20. And of course, the hoary old chestnut of training, supervision, and supports. And so we built this like process of really deep engagement and a consultative process. And I would say that has been probably one of the strengths of the approach that we've taken in North East London. It is time consuming, but it does yield real dividends. But it also created the kind of evidence base, if you like, and a rationale for action and for the next steps. The other thing that we did, because we have in City and Hackney, we have a third provider, voluntary sector organisation that has the remit for health and wellbeing coaches. One borough has 8. We decided actually this could be the potential for a really strong partnership with the voluntary sector organisation. Next slide, please. So on the back of that first phase discovery work, we established, and I guess it's not a fix that I followed Mohan and his last slide, but we established a North East London Health and Wellbeing Coach Network. And I guess often people say, why did you do that? There's the national work, there's the London work, but there is something about geography. There is something about proximity. And I guess it goes back to that point I was making earlier around sense of identity and sense of discrete, clear role remit. And, you know, we've got a coach who is the only coach in one borough, and she had no idea that there were another 22 across North East London. In one particular borough, 2 PCNs have both got 2 coaches, and they didn't even know they existed. So right from the get-go, we're able to kind of broker relationships. We're looking at stuff at scale, but going forward, when we look at the future plans, you know, there's something for us about kind of helping strengthening those relationships at a local level. We also mapped the baseline training and supervision position, which, you know, is pretty staggering. No matter what the DES says, I think there's this sort of retrofit set of work that's going on now, but all the coaches were saying, you know, absence of training, the core training that they thought they were going to get. And while there's some examples of supervision with a GP or an enthusiastic leader, the requirement around an accredited supervisor, a coach supervisor, was absent. So I spent quite a long time, I will say, exploring the PCI approved providers and developed a relationship with one particular provider and spent a lot of time, a lot of conversations with that organisation, really trying to explain to them our situation in North East London, that it's really important for a provider to understand the context within which our coaches are working, understand the deprivation, understand the complexity and the vulnerability in North East London. And it was on the basis of that and an agreement through that those sets of conversations that we were able to go forward and work with that provider. The money, yeah, it's a huge challenge, but we were able to use some workforce development funds. And so by year end, i.e. end of this month, all 23 will have completed their 4-day PCI training program. The feedback already from people who've been in post maybe for 6 months and hadn't done it yet, it's just been like a game changer for them. Part of that program, it's a 3-part program. Part of that is for 1 year monthly skills development, where they come together with other coaches online, and they're all getting 6 months of one-to-one supervision with an accredited health coach supervisor. And again, having conversations with some of the coaches, I've just said it's been quite transformative for them. So I guess that kind of speaks to, you know, what we're trying to do at scale, accepting it's not going to be kind of necessarily the sustainable model from an ICS point of view. The other thing we wanted to do is keep that relationship with Shoreditch Trust, which is the voluntary sector organisation, going. And they were exploring doing an evaluation, a deep dive in Hackney, and we were saying we want to do an evaluation in North East London. So we've collaborated and working with King's College London to do an evaluation of health coaching. And that has included, methodology-wise, that's included surveying all the coaches. Survey has gone out to PCN CDs and managers, a series of stakeholder interviews across those two groups. And the third dimension is also interviews with the provider, who will give us a real sense of the L&DS, learning and development strands. And, that is underway and hopefully will be completed by the end of April. Right, next slide. And what we're doing next, I guess we're still thinking, right? So, we're doing a bit of a pause and review. This first phase of our network has been brilliant. We're building the architecture and the foundations is how I would describe it. We're also now talking, we're polling our coaches for what do they want next from 22-23. Now that training and supervision is in place, those two real pillars that anchor them and gives their work like professional framework as well, and a framework within which to operate. What do you want next? So we'll be reviewing the network. The network will continue, but we're going to be looking at what the focus is, what the frequency is, and also bringing up, in terms of workforce development, coaches who might be interested in some facilitation training to run sessions for their peers. I'm going to use the evaluation findings from King's College London to support our next phase. Watch this space. And I guess there's also something relating to 22-23 and what Sajid Javid said, and personalisation is here to stay, which is at least equipping coaches with an awareness of the other components of the model. Because those things do emerge in coaching conversations. People are living with a lot of complexity, and it won't all, there may be other issues that are creating resistance for them to activate. It may be stuff around debt. It may be stuff around finance. So at least equipping coaches to be aware of the other strands of the model, working with training hubs. And I guess the next big phase for us is actually really cementing the work with primary care networks and primary care around the integration of these roles, because the work we're doing is not a sustainable approach. You can't do it all at system level. And, I guess how we're going to go about doing that, we've started a series of webinars at scale with all the PCNs in our local system. And then we're also going to start surfacing some examples and models of integrated working between all the personalised care roles and what are the conditions for success. Yeah.
There's so much incredible engagement happening at North East London. I'm conscious of time. Do you have time to answer a couple of quite specific questions?
Yes.
So there's a question around, so someone's just asked for clarification on the PCI training. I think you mentioned it was from workforce development funds. Can you say a bit more about that and how much it was roughly per person?
I literally can't remember how much it was per person, because we're working through the funding that all the ICSs were accessing around workforce development. I think because we had some coaches who had done the PCI training last year, we had two different packages. So we had the package for those ones who'd already done it. We were offering the 12 months of skills development and one-to-one supervision. And for everybody else, it was the 3-part package. But I'm absolutely fine about sharing who we used and like unit cost for one person, if that is helpful, which I can do after this.
Yeah, we could definitely pick up with that.
Yeah, sure, no problem.
You've obviously been really involved in the other roles, especially social prescribing. How do you see the health and wellbeing coach working alongside social prescribing, and where have there been some tensions or anything to iron out, or possibly some really kind of like rich opportunities?
Yeah. So it's really interesting, because one of the things that we discussed in one of our network meetings, I think possibly actually the one we had on the 1st of March, was like, who do you interface with other PCN linked roles? And there's absolute synergy working quite closely with this. I don't think we're experiencing much tension with social prescribing. I think actually there's synergy, because if someone is presenting, has been referred, the reason they've been referred, often by a clinician, to a health and wellbeing coach, is one reason. What happens in that conversation will surface a whole slew of other things that will absolutely explain why someone may be struggling to be activated in medical speak. And actually, the quality of the relationship between the coach and other social and the social prescriber will really, enable those things that are pressing on someone's mind. If you've got debt, or if you don't have heating, or if you can't pay your bills, what the likelihood of you being activated is is pretty low. And because those things are pressing on your mind. So that kind of collaborative between those two is really key. But I think the other thing that's really interesting that emerged was we made this assumption that they're aligned to, it's this sort of personalised care workforce, 3 care coordinators, social prescribers and coaches, as this kind of in a team. But when they mapped out who they interface with, occupational therapists, a lot of work with dietitians, and other roles. So it's been really interesting, kind of disrupting some of the assumptions that I personally had as well.
Amazing. Thank you so much, Geeta. There's tons of other questions, but we can definitely follow up. We're going to let you go.
And I've only got to dash because we've got our social prescribing leaders program today. So we've got to go and launch that this afternoon. But thank you so much for having me. If anyone's got any questions, my email's on my front slide. Feel free to reach out or go via Leanna and the gang at HLP.
Thank you so much.
Thank you. Take care, everyone.
We've got 5 precious minutes left with Caroline. I think it'd be good to go back to Caroline to discuss, to just hear from a health and wellbeing coach perspective as to, are you there, Caroline?
I am, yeah.
Yeah, great. To hear from you about, so I mean, lots of what Geeta's been talking about is, I guess, how to create a network, how to create that network and think about the wraparound support for health and wellbeing coaches. But it would be good to hear a bit more from you, from the front line, what you think that PCNs can be doing to embed these roles and really kind of support them to get the most out of them.
Yeah, great. So I'm going to just spend 5 minutes talking about how best to support health and wellbeing coaches in their roles. And these next couple of slides, I've got on the left-hand side the challenges. And now these challenges have come up mainly through peer support sessions, but also through a survey that was done to all health and wellbeing coaches. So these are I've kind of cherry picked the main challenges. So that first one, it was found that there was a lack of ongoing professional development for health and wellbeing coaches. Now, as we've already talked about, all health and wellbeing coaches as a minimum need the 4-day accredited health and wellbeing coach training. You can't expect health and wellbeing coaches to sit in front of patients and do their work if they're not trained to do it. It's a huge risk. So obviously that at a minimum needs to be done. And then because this is such a new role, all health and wellbeing coaches are going to be coming to this role with huge varying backgrounds. And so their training requirements are going to be quite different depending on what their background is. So really making sure that if you have health and wellbeing coaches in your network, where they feel like they're lacking in knowledge or they're lacking in training or where they feel like they need more support. So really asking them what they feel like they need and then encouraging them to get as much training as possible and to, ensuring that they can do their job in the most effective way possible and making sure that they're given time to do that training as well. They're not expected to do it in their own time. And then lack of supervision. I mean, this has come up a lot so far. So that coaching supervision, obviously the clinical supervision, I think that's a given and that's relatively easy to get. It's the coaching supervision that sounds like it's a real problem, and that's certainly what's been coming through when I've been doing the peer support sessions. Sounds like we've got a really good example in North East London that Geeta's just been talking about. And in South East London, we've just managed to set up supervision from coaching supervisors as well. And as Geeta was saying, that can come through there's 4 different providers that provide the health and wellbeing coach training, and they can also provide supervision. So if you're purchasing training, you can normally get it as a package, so the training plus supervision for a certain amount of time, or you can just purchase supervision separately as well. Obviously, there's a cost, and I think that's the biggest obstacle at the moment is the cost. I know we were talking about costs earlier, so I've got the cost for supervision actually, if anyone's interested, and actually for group supervision, which is what we've set up for South West London, it's £400 plus VAT per session, and that's for 5 to 8 coaches. So it's not a huge amount of money. It's just, well, you know, it depends on how many coaches you've got, obviously, but it is funding that you do have to get, unfortunately. And I guess the real why supervision is really needed is because coaching is potentially very different to most of the other roles within a PCN, and coaches need to have need to know that they're doing the job right. We need to have some sort of consistency across the service and know that, you know, the health and wellbeing coach in that PCN is doing it in the same way as a health and wellbeing coach in another PCN. And, you know, just to make sure that everyone's running their sessions in a similar way. And then the next challenge we found was that about the peer support. Now, Geeta outlined this really well a minute ago as well, so I won't talk about this too much. But, you know, there's a lot of support out there. There's the London peer support, there's national peer support, and there's, you know, forums for health and wellbeing coaches. So just making sure that they're linked into all of these different supports and to make sure that they are utilising them and they've got time to attend them as well. Next slide, please. So another one of the challenges is varied understanding from practice staff. So some people might have a really good understanding of what the role is. Some people might have slightly less understanding of what the role is. So if you have health and wellbeing coaches, make sure that they're given the opportunity to talk to the members of staff. So invite them to meetings, you know, help them to promote the service, help them to, you know, create events where they can tell everyone about health and wellbeing coaching and really promote the good work that they're doing. Bad referrals or a lack of referrals, this is linked to the varied understanding from practice staff. You know, if people don't understand what the role is, if clinicians don't understand what the role is, then they're not going to be referring the right people. And especially because there's so many new roles at the moment, and social prescribers, for example, have been around for a lot longer, and clinicians might feel very comfortable referring on to the social prescriber. So they might refer everyone onto them and none to the health and wellbeing coach because they don't really understand what it is. So it's really just making sure that everyone knows who, you know, the patient is being referred to the right person, basically. And then talk to your health and wellbeing coach, make sure that they, you know, understand who they're getting the referrals from. So there might be some people that are referring lots of people and really good referrals. There might be some clinicians that aren't referring anybody. So really trying to create an environment where everybody is comfortable referring and make those referral pathways easy. You know, you don't want loads and loads of clicks, loads of big forms to fill in. Make it easy and make it quick. And then feelings of isolation. This is, you know, a lot of health and wellbeing coaches are working remotely, partly potentially because of COVID, but there's also room space issues in a lot of PCNs as well. So if people are working remotely, these feelings of isolation can be enhanced. But even, you know, there might be health and wellbeing coaches working across a number of different surgeries. So if you're only somewhere for a few hours, you know, it can feel quite daunting going into a new place. I'm sure you've all felt that before when you've gone somewhere and you think everyone knows everyone, and, you know, I don't know anyone and I don't feel like I belong here. Or you might get there and there isn't a room available, and, you know, what do you do? And you feel like an inconvenience. So it's just making sure that they're included and everyone knows to expect them and they've got a room allocated and all of those things. The next slide, Jenny, I think was an amalgamation of the slides I've just talked about, so you don't need to worry about that one.
I just, before you, if you've got one more minute, it would be really great to hear. So we've got Caroline prepared some examples of case studies across London. Any particular standout ones? I'm wondering if it might be worth talking about the long COVID work that you've been doing.
Yeah, you can skip this slide. Northwest, just to that Northwest London one, this is a really great example of self-referral. So Babylon, the GP at hand, there's 2 health and wellbeing coaches there, I think, and they were saying how they've tested this self-referral route, which is working really, really well. So they're identifying cohorts of patients and then sending out a text message saying this is a bit of information about health and wellbeing coaching. We've identified that you have this certain condition. So they've tested it for SAD, obesity and diabetes. And actually the patients who self-refer are much more engaged, and it's a much more effective coaching experience than the patients that are referred by the GP, because these people are looking for help and they've already decided that they want to make a change. So they self-refer rather than the patients that are referred through the GP. So that was a really interesting example. And now we can move on, please, to South West London. So South West London, I'll just talk very briefly. In East Merton, we've been doing some long COVID group clinics, which have been really effective. Some of those virtually, following a kind of VGC type format with a GP, health and wellbeing coach and a care coordinator. And that's worked really well. And we've also done some in person. And then across the PCNs in Merton, we all collaborated recently to provide a workforce wellbeing session focused on employee wellbeing that we delivered a couple of weeks ago, and that worked really well as well. And it was a really great way to collaborate across PCNs as well. And that's it, if that's okay.
It's been really, really helpful, and thank you so much for sticking around past the time that you had to leave. It's much appreciated. Thank you so much, Caroline. There's some really interesting questions coming through. We definitely will be picking up lots of these questions outside of the meeting, and some of them I think it would be useful to if we come back to Mohan to talk about the 3 roles. Sorry, we're jumping around a lot today. I think everyone's got really busy schedules right now, and hopefully this is, you know, some of the presentations that are coming today are useful. Are you there, Mohan? There's also going to be some, there's a couple of questions that are coming up in the chat that I think we can cover with the people in the room, but also maybe it's useful to spend some of the last sort of like 10 minutes to ask some of these questions of each other. There'll be some people in the room that have probably got some answers to these questions. Mohan, over to you again.
Yeah, thanks. I mean, it's sort of recap really of what Caroline's mentioned, and I think certainly linking with the other roles, we've got lots of these roles, haven't we now, which are fantastic. In South West London, we've got 60 social prescribers, 60 care coordinators, and now 15 plus health wellbeing coaches. So you can suddenly see a nice army of non-medical roles to really help support what needs to be supported. So I think with the social prescribers, really identifying what their role is and how it fits into the network, to the practice, and I put it in the chat box as well about making sure that workers know what they're doing, and better still, that the people who are referring in knows which service to send them into as well. And you know, social prescribing, looking at some of the social issues to behaviour, health wellbeing coaching, looking at one-to-one behavioural type role in terms of getting them to do what self-manage, empower them to make decisions for themselves, which can then enable them to look after long-term conditions. So really, really key. We also found social prescribers who are upskilling some of the health wellbeing coaches about what services exist. So that's a really good sort of relationship, which is also key, and vice versa as well. And there is a bit of element in terms of some of the training and how they deliver their consultations. But in terms of the referral routes, I think they are slightly separate. The care coordination, again, they coordinate the care. They're looking at long-term conditions, sort of finding out that the patient understands what happens. They can also flag any sort of reviews which the patient may be needed. So I think, again, those 3 are really key, but it's important that you identify what's needed for your network and your practice. Video group consultations, absolutely massive opportunity. And I think not making it GP focused, but actually making it either health wellbeing coaches focused or social prescribers or even care coordinators as well. And actually they can take the lead in this in terms of really addressing which patients need which support. It can be a really powerful tool as well. Health wellbeing coaches in the workplace, so both the patients and for the staff as well. So we do some yoga here, which is done by the care coordinator, who's soon to be a health and wellbeing coach. And that's really powerful as well for staff morale, and also, again, getting the message out there. So a good influence, a really good influence in terms of the staff practice. And then again, linking into the wider determinants, and also what it is in your network you're looking at. So we're looking at obesity in a big way. And so how can we link them into our community assets? So, getting a health and wellbeing coach to talk to our community assets, and also finding out what weight management services currently exist, giving them the obesity register as well. So you can suddenly give them a nice, tidy area to look at, which resonates and actually is a big problem, something which they've been working on themselves and are the experts in that area. So I think lots of opportunity there in terms of how to link in with these roles, but it's really important to understand what their role is. I think if you don't understand what their role is, then you won't use them effectively, and therefore not get the best outcomes, which will then impact on your perception of what they can deliver. So I think back to basics is find out what they can do, which Caroline's really illustrated today, and really make sure that you fit your criteria to that cohort, and then you'll see the right evaluation come as a result of that, and see the impact. Thank you. That was it, Leanna.
I saw some that we were talking to somebody earlier in the week who was talking about kind of the number of health and wellbeing coach interventions that it would take to say, I think it was like 2 or 3 health and wellbeing coach interventions that would save 7 or 8, in some cases up to 12 GP appointments. So I think it's like thinking about what the needs of your population are and targeting particular groups that are really going to benefit from this, and work with the things that Karen was talking about, motivation, those that have got the motivation and kind of feel trapped and need that extra support, I think is really important. There was a question which I feel I'd be really interested to hear your answer to, Mohan. What does a good induction for, because I think one of the things that you guys did really well in Merton was think about how the health and wellbeing coach could be used before they landed. I think it's all too common for these roles to land in primary care and almost to retrofit what we think they might end up doing, and sometimes that means they then end up doing some of the more administrative tasks and not necessarily getting into the meat of the role. You spoke a little bit about the thinking that you did before somebody arrived. What do you think a good induction for a health and wellbeing coach looks like?
Yeah, so I'll probably define what induction is. Induction for me is that bit before they arrive, the bit when they arrive, that first few weeks, and then induction carries on, into the first few months. And once they're fully embedded, then that induction process finishes. In fact, when our health and wellbeing coaches came to Wideway, I actually stalled their start point because right in the middle of the storm last December. So look, don't come now, it's just crazy, it's no point. So we actually started a bit late. But the induction starts pre-planning, so making sure everyone's on board, that there's a party coming, or there's a health and wellbeing coach coming. So when they do come, they're expecting her. She's not like, who you, go away kind of thing. They're actually opening arms, welcoming her in. She's got a room, she's got a timetable, people know what she does. So you do that sort of pre-planning. I think when she starts that induction, as with all roles, get to meet the other staff, get to find out what they do, induction on the computer, know what the work environment's like, and then what her role involves itself, and who her points of accountability are, and then who her supervision are. So your supervision at the beginning will be more frequent, and then as the job gets bigger, or as you progress, then obviously they'll get longer in between. Attending staff meetings, clinical meetings, knowing where you can feedback, that's all really important, and then continuing that feedback loop, so you kind of catch up with the clinical supervisor at the practice to make sure that all's going well or not going well, as the case may be, and then you react to it. What you don't want is problems to arise, not doing about it, and then bigger issues arise. So it's similar to all roles, I'd imagine, but in particular health and wellbeing coaches, because they're new to primary care, as well as social prescribers were a few years ago. They've not had any NHS experience, and I frequently say, how's life in the NHS, because it is a very different atmosphere. So I'd say there my point is while they're in post for the first few weeks, and then that first few months, so the induction continues.
Yeah, it's so important actually not to think of it just as the weeks that they're landing, and the pre-work that needs to go on, so there's some clarity around the role, how they're going to be used, how they connect with the other roles, and some of that you are going to decide as you go, and you'll need to iterate, because obviously there's lots of reasons we're working in different ways these days. I'm going to open, thank you so much, and it'd be great if you could stick around. We've got another 15 minutes and there's quite a few questions in the chat, and I'm wondering whether or not there's value in opening it up to the room. There's not many cameras on, but I'm wondering, I'll take a bit of I'll risk it for a biscuit. And I think that last question about the induction, it'd be really interesting to hear from any health and wellbeing coaches themselves, or maybe people that are overseeing. I can see some people in the room that manage health and wellbeing coaches, about some of the things that are really important. And I guess one of the questions that came up earlier actually is, how long should a health and wellbeing coach be spending with somebody? We know that the personalised care roles are there to give vulnerable people that need extra support the time. But so it'd be good just to hear from the room what people are doing. This is, you know, for people to meet each other as much as for us to hear from kind of the specialists in London. So anybody want to take themselves off mute and talk a little bit about what they do induction wise and how the health and wellbeing coach works? Val, I don't want to single you out. Val Dev in Hammersmith and Fulham.
Okay, I can do.
Putting you on the spot. Well, I mean, I just know that you manage a couple of link workers. You manage the health and wellbeing coaches alongside the link workers, and it might be interesting to hear your perspective on
sorry, I'm trying to get my camera on. There you go. Around induction.
Yeah, exactly. How they can work with the other roles, like, you know, yeah, a little bit about how they're working in your patch.
Well, really, I mean, it was just the same as what everyone else has said. Usual induction with us, it's a GP federation. Induction then with the individual practices. They also then did some shadowing with the other health and wellbeing coaches and another PCN. And then we embedded them into the link worker team, the wider team. And they've also got within their PCN a sort of peer-to-peer support as well. So that's kind of what we did around induction, which, I mean, with all the mandatory NHS training and everything, it does take quite a few weeks to do induction. With regards to sort of what else has been going on, I think generally I've been very lucky because I've got two very proactive health and wellbeing coaches. So actually embedding them in hasn't been too difficult. I think there's still this issue around knowing your colleagues at each of the practices, because they've got a number of practices and they only tend to spend one day at most at a practice. So, you know, how do you get to know those wider colleagues? Also, you know, as people have said, how do you differentiate between that role and the link worker role? It's a new role and people don't necessarily understand the concept of coaching and motivation. And also that what has been said earlier about sending out mass texts, that's been very fruitful for one of the health and wellbeing coaches, where they've perhaps not had as many referrals from the GP, but that again has worked really well. The conversion rate has been high, so we've been really lucky with that. At the moment, we're sort of developing what the group coaching sessions will look like in the future, and they're sort of looking at two sort of concepts, one around the 5 ways to wellbeing and another around just healthy lifestyles, and trying to get those set up and what they will look like. So it'd be really good if anybody's got any of those going on, any ideas about how to sort of run those sessions, that would be good to hear.
Yeah, that's a really good point, and I think this is what these kind of sessions are about, is like trying to crowdsource some resources and some approaches and different ways of doing things. If anybody's got, does anybody have an answer to that actually now? Anybody doing any group work and have tried some different approaches?
We've done some video group consulting, and we Agnieszka is our care coordinator, soon to be a health and wellbeing coach. She pretty much drives it all the way through. She got trained up with is it Redwood or Redbrook, who's a training organisation. They managed to go through it with her. I mean, I'm sure we're more than happy to have a conversation about how she set it up. It is quite intensive setting it all up, but once it gets set up, you've got a great resource. But yeah, happy to link you in with her if needed.
There's definitely some other examples that we've come across in other bits of London, so we can pick that up outside of the meeting.
Or maybe arrange for Redwood or these people, these facilitators to do a meeting. They did one in South West London, and we all logged our interest. And then we managed to train up lots of people around it. It worked really well, actually.
Actually, this is a really good point. Maybe there's one of the things that Caroline does is host a monthly meetup for Health and Wellbeing Coaches, Pan London, and quite often they'll have a speaker or somebody that can deliver some content. So maybe there's something around kind of offering some training around that. That's something we can pick up and look into. Thank you so much, Val. Sorry for putting you on the spot. Is there anybody else that wants to share what they're up to? There was a question actually about kind of whether or not these roles are supporting cancer patients. So we know, and I don't want to come back to Val, but we know that social prescribing link workers have been really instrumental in some cases, and there's funding coming for specialist cancer social prescribing link workers. Has anybody got any experience or have been doing any work with cancer patients? Quiet, it's all quiet.
I've got a couple of comments. I mean, I think for me, I wouldn't see a patient as their condition. I would see them as themselves. So there'll be an individual with cancer, an individual with diabetes, an individual with asthma, an individual with learning disability, and you need to base the need on what they need and regard their long-term condition or what their treatment, that their condition is as a separate entity. Obviously, there will be a bit of link in terms of what they can and can't do, but the social prescribing is looking at the social issues, and the health and wellbeing coach looking at the behavioural issues, which is irrespective to their long-term condition. Having said all that, there are some specialist roles, which are looking at Macmillan Cancer, looking at social prescriber link worker roles and referring patients with cancer to them in a couple of places across London. But broadly speaking, the themes are similar. You know, what stops these individuals from living their life tends to be the social issues or the behavioural issues. So that'd be my comment on that. Thanks.
Thanks, Mohan. Any other burning questions from the room? So we've got, I'm just looking at the Slido, we've got, we've covered quite a few of these now. How much does time does somebody need with their clients? I mean, I would say from the Health and Wellbeing Coaches I'm hearing from, it can take up to an hour. Would you agree with that, Mohan, or any other Health and Wellbeing Coaches in the room that have got a comment on how long a Health and Wellbeing Coach needs with its clients?
We've tended to go with the same time as what a social prescriber does, and again, depending on what their follow-up review needs may be, it may be shorter, longer, etc. But yeah, it does need that slightly longer time, than, especially with evaluation, the ONS4 and the PAM when it was around, you know, does bite into some of your time of what you want to do, but it needs to be done. So yeah, I think it resonates with that.
Hi, Leanna. Our health and wellbeing coaches have actually said they prefer 45 minutes. And the reason being is that they need that other 15 minutes sometimes just to process the information that the patient has told them, because it can be quite overwhelming. So generally we do 45 minutes and give 15-minute admin time and just a break between seeing the next patient.
Very sensible, very, very sensible. And as somebody's saying in the chat, it would obviously depend on the individual and the situation and what it is, I guess, where you're at in the coaching cycle. There's one last question about kind of how many how many health and wellbeing coaches are needed for a PCN. I think, you know, my thoughts are that it's a lot of what Mohan's been talking about. It's dependent on the population health needs of the PCN. But do you want to take that one, Mohan? And anybody else from the room, if you want to unmute yourself and give a comment?
Yeah, again, I think it's similar to what I've mentioned before. So you can have a lot of health and wellbeing coaches, but if they're doing the wrong thing, then it won't be impactful and effective. Or you could have one health and wellbeing coach doing the right thing, and that can be hugely impactful. And there was a question before about whether they should be doing vaccination counsel for children. And if you've got 4 health and wellbeing coaches doing that, then that impact will be low. Whereas if you've got 4 health and wellbeing coaches doing diabetes, let's support what matters to you. You know, that's huge impact. So again, yeah, I think it's what works for you. I think the social prescribers is estimated that we should be having up to about 4 per network. But aligning that with your health and wellbeing coaches, again, what you need maybe, I would say probably similar to that. But I'm biased. I would certainly go for, you know, once you see the benefits, you'll find out how many you need.
Yeah, well put, very well put. I think, you know, there's definitely some there's growth, you know, there's room for growth with these roles, and thinking about how they're going to be used. Obviously there are many of the PCNs now that are starting to see growth in their teams, are building a bit of a personalised care team of people. They've seen some really interesting examples of where social prescriber link workers operate a hybrid role. And I think where that's happening, it can, you know, if they're attached to one surgery, so they have a really good relationship with the population of that one particular surgery, as long as they're clear when they're wearing a social prescribing hat, or when they're wearing a health and wellbeing coach hat, or when they're wearing a care coordinator hat. It's really important for the patient that they're supporting to know what kind of intervention or what kind of engagement or conversation they're having with the individual. But there are some cases where that can work quite nicely, where an individual's attached to a surgery. Thank you so much for everybody that's contributed today. And I'm going to hang around for 5-10 minutes after the session if anybody wants to stop and say hi or ask any questions, or but yeah, we will be circulating the recording and the slides and some answers to the questions that were asked today, so you've got those in writing. And that will start to inform the toolkit that we're developing for these 3 roles, and hopefully we'll be supporting PCNs to think about how to embed these 3 roles. We've got another session coming up next month. We're going to be looking at Jenny, are you there? Do you want we're going to be looking at the use of data. Do you want to say something about next month's session?
Yeah, sure. So next month is going to focus on how the 3 roles can take a population health approach to tackle health inequalities. So giving some real practical tips on how you can start looking at your population needs, how you can start engaging with your communities and different organisations to look at population need and not just kind of keep it NHS side. That'll be on the 20th of April, and I can share the link in the chat and it will be circulated afterwards.
Thanks all for contributing, thanks all for coming, and yeah, I hope to keep in touch and see you soon.
Thanks all, cheers.